Section 5. Hope everyone is doing well, and this week 5 wrap up finds you all well. It was a great week. I really enjoyed the discussions. Lots of really good information being passed around. I'm going to try to be quick because this thing could go a half hour easy if I'm not careful. So let's get through some of the kind of the highlights in my view of the weekly readings. 90% of ACLs will be reconstructed to the tune of $3 billion per year. That's a big number, and not number of you mentioned that in your post. This is big money, right? It's not low back pain big money, but it certainly is big money. That's why at the bottom of I believe it's Aspen, the Steadman Hawkins Clinic literally has a clinic at the bottom of the hill on one of the ski slopes. People are thinking surgery first, and we're learning more and more that is not okay because there are better options for some people. So, copers versus non-copers. Surgery doesn't seem to determine the success, whether they're a coper or not. The non-copers need help. Fear avoidance becomes a major player for non-copers. Perhaps. It's interesting that we start to see fear avoidance pop up in a variety of different things. That's why the biopsychosocial model becomes really important. We need to continue to explain pain science to our patients. We need to continue to show them that they have control over the situation and get their brains to be less vigilant, perhaps, about what is happening. But maybe in the future, fear avoidance, the FABQ may be a role in determining how we treat these people. I think the numbers at the bottom, best determined by 10 visits from 60 days to 6 months, those are critical numbers, and I think those are important to have in the back of your mind as you educate your patient. The problem is that people get antsy. Man, they want that quick fix. They start thinking about timelines, especially if it's a return to sport, a high school athlete, a collegiate athlete, perhaps somebody who just enjoys a particular thing and they want to get back as soon as possible. And if they know they have to wait to just determine, they get antsy, no question about it. But we need to do a better job of educating, because I don't think we can rely on the surgeons to educate. They're less likely to do that. There are some, but they're less likely to do that. In the meniscal, articular cartilage and meniscal injuries, the weekly readings, I'm not going to go into great depth. I thought it was really good what Eric Robertson had put together. I think the important thing is to consider the good prognostic indicators and the poor prognostic indicators as you work with your patients and try to continue to steer them, knowing that the younger patients are going to do better. Poor prognosis with older patients. Strengthening continues to be a huge issue. Complete tears versus longitudinal tears, and how those and the mechanical locking too. That stable knee at the bottom versus unstable knee. Are they able? And I think that stable versus unstable, you might as well write coper versus non-coper, right? And then lastly, the special tests. I think that these special tests are important to keep in the back of your mind. The specificity is fairly high on most of them. Apley's perhaps being the least, knowing that McMurray's is probably the way to go. But interesting how joint line tenderness, if that's negative, that's a true negative test. I always like it when obviously getting high sensitivity and specificity are important, but if we can use one test to do one way and another test to do another, then we can be a little bit more confident in the entire picture. Okay, so the Heiderscheit article on the hamstring rehabilitation, the swing phase of gait is really where all this happens in the second half, that deceleration phase. The biceps femoris appears to be the main target, typically the one that gets dinged the most. Severe injuries resulting in tears in hip flexion and knee extension. The only reason I threw that in there was because I think as we talk about minor versus major tears and complete disruptions, we have to be able to differentiate in our minds perhaps when an MRI might be warranted, especially in a direct access kind of issue. Eccentric loading is the key to rehabilitation, man, whether it's a tendinosis in the patellar tendon, or it's a tendinosis in the Achilles tendon, which we'll talk about more in week 6, or it's a lateral epicondylalgia. Eccentric exercises continue to demonstrate their importance within the rehabilitation process for any kind of tendon-related trauma or chronic tendon pain. The PDVT Wells CDR, becomes extremely important, and it's the best way to keep your patient safe. Man, if we're still doing the Homans test, that is... I commented on a couple of people's that I can't believe it's still being even taught in school. There should be Homans with a circle and a bar through it, and then we should then just follow into the Wells clinical diagnostic rule. the CDR, that's what we should be using. And because when you looked at those clinical vignettes where some PTs were getting it right 15% of the time versus 90, that range is way too variable. It needs to change. Points of conversation. So I thought in continuing to monitor your threads, there's just some really good stuff. Travis, Alicia, and Casey all had a good discussion about the importance of eccentric training and pelvic stability. I think, we're learning more and more about, again, eccentric training being a really good thing. I like Joe had a great program for eccentric control. He even laid out some numbers that I thought were really, really interesting. I liked how he was very specific about that. Meredith also, I really liked her responses about her compelling strategy about hip control and retraining those with hamstring injuries and some of the stuff that Powers is working on. I couldn't agree more. I think that there's a lot of validity there, and in the future, we'll continue to look at the hip, man. The glutes are huge. The pelvic stability is huge. Strength in that area is a big deal. I liked Jason brought up the importance of slump testing, and especially with those who are more flexible. Slump testing with hamstring injuries was something that a lot of people seem to be addressing. Was not something that was news to most. The thing that drew me to Jason's comment was how you have to sometimes be fairly aggressive with some people who are more flexible. His example was females. I have seen it in some males, but I do think that you can tease out neural tension. You have to make sure that you're teasing out neural tension the appropriate way so that you are getting so that it is a neural sign. And sometimes a lot of chronic hamstring strains that may be treated eccentrically that aren't getting better, you certainly have to look at the neurodynamics, because if you're not, you're going to miss a huge component of this. So Ray had an excellent point regarding the rigidity of protocols. Do we need to follow this to the letter? These ACL post-op rehab protocols, I thought, we've come so far that with ACL reconstructions, in my mind, it's really about what patients can and can't do, and we progress them to tolerance. And everybody kind of seemed to do that. There weren't anybody who was really timeline dependent. It's really about it's really more about patient dependence and what they can and can't. Can they stabilize or can they not? And then can they progress accordingly? I think that's a huge deal. We have the single leg, the triple hop, the distance hop. All those things help us know when it's appropriate to return to sport. I love Payal's comment about with her patient who was a physician who was rehabbing his ACL and was recognized the delay that he needed to go through to wait to meet the protocol requirements, and that she challenged him. It's always interesting how when you actually live in the moment, when it actually affects you, things change. Funny how that works. That was awesome. I could go on and on. I'm not going to. We had really good discussion. Everybody seems to be on the same page. Lots of good stuff to talk about. Lastly, I will comment on the Roger Carey stuff. Roger Carey is a great, practical, evidence-based researcher. For those of you who were able to comment, I know it's not everybody got there, and I know it was an add-on, but I do think it's worth your time. And I love the comments about people, Justin talking about common sense, and he's right. And I think that that's what Roger Carey would say. Common sense is a big deal, that we don't get carried away by the latest and greatest, that we use or that we put aside things that maybe have gotten us through in the past, that we and the term maybe throw the baby out with the bathwater could be applied, but that we are practical in our approach, that we are reasonable in our approach, that we take the time to fully understand what we're doing, what we're learning, and that we don't get caught up in a wave of hysteria. And some people could use the dry needling as an example. Depending on what your approach is, depending on how you integrate that into practice and how you see that affecting your entire practice. If you think that dry needling is the way right now and all your patients get needled, you could argue that that's probably not okay. And yet there is some research that would say that maybe I should be thinking about this and incorporating this in certain ways in my practice. I think that's his point was we need to be thinkers. Please be a thinker. If nothing else, hopefully this type of coursework has taught you to be a thinker. So, moving on to week 6, Achilles tendinopathy and plantar foot pain. These patients can be a challenge, no question. We've got the group projects. If you have not made contact with your group, please do so. Very, very important. Finally, fellow case studies will be week 6. Fellows, if you contact me if you're confused about what you need to do, I just got an email from Julie again reminding me about the information that need to be passed on. I will be doing that soon, but if you are confused as to this is a different case study because you'll be listening to different information, please let me know. Okay. Again, good work this week. I look forward to hearing from all of you in week 6. Get in contact with your groups and get started on that stuff. And if you have any questions about that, please let me know. Otherwise, have a great weekend. Take good care.